Evening, everybody. I welcome you all. Dr. Ganesh also has joined in faculty. I welcome especially Dr. Hartman. Everybody knows him. The Neobladder goes by his name, and is happy to have him here under SOGO, society which is focusing on uro-oncology, patients' care, knowledge sharing, and any advancement which can be taught to the all the young doctors and other people who are interested in this. We have got the registration done, and now we'll be proceeding with other activities. Hopefully, whenever the pandemic is over, we will come with the in-person conference. So today we have Dr. Hartman, who will be sharing his experiences and other parts of Neobladder, which we have rather read in the book. And I'm happy to say that I have interacted with him personally many times. And now I'll ask Raghunath to introduce him, and then we will start the actual talk after inviting the chairpersons. Raghu, please.
Thank you, sir. Very good evening to all the office bearers of SOGO, all the faculty, and the urologists and uro-oncologists, ladies and gentlemen. You all know continent urinary diversion via an orthotopic neobladder offers distinct advantages over an ileal conduit. There are many types of neobladders. Some are widely known, while others are highly distinguished. Hartmann's neobladder is one such neobladder. It stood the test of time. This scintillating evening, I call this as scintillating because it is lifetime opportunity for all of us to interact and learn from an innovator. We have Professor Hartman with us, who is the designer, creator of this neobladder. It is my proud privilege to introduce Professor Richard Hartman, Professor of Urology, to you to talk about his work, accomplishments, and innovations. Probably we need 3 to 4 more webinars. Due to paucity of time, I would just take 3 to 4 minutes to introduce Professor Hartman. He completed his MD from University of Germany in 1969, got his board certification in 1974. He became the Professor of Urology at University of Ulm in 1984, served as Dean of Faculty, Clinical Medicine in 1989. He became the President of German Society of Urology in 1993 and Chairman, University of Ulm Department of Urology in 2009. He is a member of various international urology associations. To name a few, American Association of Genitourinary Surgeons, AUA, EAU, and SIU, and Urological Research Society. He received various distinguished awards, again to name few: Pence Medal, German Cancer Award, NETZ Medal, European Section of Oncological Urology Achievement Award, EAU Lifetime Achievement Award, Distinguished Career Award from SIU, and Laurent BG Award from Association of Academic Urologists, Association of Academic European Urologists. To his credit, he has edited 5 urology books, and he published more than 500 scientific articles in a peer-reviewed journals. His major scientific interest is in the field of cystectomy and neobladder. He served as the editor-in-chief of a journal called Urology from 1984 to 2009, almost for 25 years. Urologists world over are really inspired by his work. His talk today would help all of us gain a lot of insights into this neobladder, as he is going to demystify the facts of neobladder and giving us a lot of practical ideas and tips, which certainly we can implement in our clinical practice. Please join me in welcoming Professor Richard Hartman. So thank you for this opportunity to introduce this distinguished guest. It's my proud privilege. Over to Dr. Sudhir Raval sir again. Thank you.
Can I speak now, or?
Sir, Sudhir Raval sir.
First of all, thank you very much for these kind words. Wonderful. I like it. But what I like much more is to be tonight with you in India, even when it's not person to person, but on the internet. But that's the new way to go, and we have no other solutions. Thanks for inviting me. Thanks to SOGO. Thanks to Suti Araval for making the contact and bringing me to you. I look very much forward to talk to you, to present to you, and finally discuss with you or look at cases together with you. What I'm going to do, I have two presentations. One is ultra long-term experience, 35 years, from the beginning of neobladder times in Ulm till to the end. And in the second talk, I will talk about neobladder thoughts, why it works or why it will not work so well or why it will not work at all.
Thank you, sir. I'll just introduce the chairperson, Dr. Jagdish Kulkarni, who is president of SOGO, and he is one of the senior most uro-oncologists working senior most uro-oncologists. There was another uro-oncologist in our country, Dr. Murli Kamath, who is not working now, and that is why actually we invited him to become the president of SOGO. He did not ask it for. Then I have another chairperson, Dr. P.B. Singh, who actually inspired by your neobladder, and he's the first one to do neobladder in the country. So with that, I'll invite both the chairperson and then they can start the program. Only thing which I'll say that after finishing one talk of Professor Hartman, please invite the question and answer. Then after second talk, again we can invite the question and answer. This is how the plan will be. And later on will be the panel discussion, first by Dr. Ganesh and then by me. So Dr. Kulkarni and Dr. P.B. Singh, please.
I'll go ahead. Good evening and welcome, sir. It's been great to have you. And can I request you to talk on the functional outcome and complications of ileal neobladder reconstruction, 3.5 decades experience. Please go ahead, sir. Thank you.
Okay. Yes, Ms. Yeah. Functional outcome and complications. In a special set of patients, I will go to explain this to you in a minute, and it's great. Okay, once again, you can see the title here, 35 years of experience from a single center. What I would specifically address, the ultra long-term complications of the true neobladder. That means for the first 6 to 8 years during the process of maturation, this is not by definition a neobladder. It is a gut segment flushed with urine. So what I'm going to present to you once again is the complications and the results after the maturation has been completed. This here is the selection of the study population. In the right lower corner, you see 1,600 patients, excluded all the females, excluded.
Really more courageous. Like we were really afraid. He's just finished like.
Was that for me? Excluded are also all the patients who had a tumor recurrence, excluded missional data, clearly irradiation and undiversion. This leaves a highly selected cohort of 259 patients within that gray box. No females, no tumor recurrence, no irradiation, no undiversion. I admit this is a highly selected cohort, but this guarantees the ultra-long follow-up. Here you see of the 259 patients, I'm not reporting the first 5 years, and here you see the fate of these patients until the last one has died. The patients clearly are relatively healthy. They are relatively young, 32 patients younger than 50 years, ASA 1.7, 50 to 60, 60 to 70, and above 70. And here the distribution of ASA scores for the 259 men. ASA score 1, 2, 3. Nothing exciting about that. Pathological characteristics, organ-confined tumor. Most patients had organ-confined tumor, not a particular wonder because we insisted the cohort should have no tumor recurrence. So the majority of our tumors were organ-confined tumors, and also the lymph node rate is remarkably low, but that's owing to the fact that no tumors recurred. Median age at the time of radical cystectomy, 63 years. Median age at the time of the survey, 12 years later, 75 years. Median follow-up in these 259 patients, 121 months. Nevertheless, these were patients and they had comorbidities, what you can see here: hypertension, diabetes, atrial fibrillation, chronic obstructive pulmonary disease, heart failure, chronic renal insufficiency. As we all, this was our limit for constructing a neobladder. Summary of the patient selected. Once again, this cohort is highly curated and subject to multiple biases. And it is not a real-world scenario, because there we have tumor recurrence. Again, females excluded. The reason for that is we started females 10 years after the males, so their follow-up is too short to be included into this series. No recurrent tumor, no chemo, no pelvic radiation. These are the fittest patients we have. The first, no, we must, okay. Can you see these figures here in the right lower corner?
Yes.
Okay, I can't, but I know it. On all the figures to come, or on many, you have on the left side the patient age at the time of surgery. They all look similar, but present different things. Younger than 50, 50, 60, 60, 70, and above 70. And here, patient age at the time of the questionnaire, at the time of surveillance. Under 50, 50, 60, 60, 70, 70, 79, and above 80. And here we report spontaneous residual-free voiding. Overall, it was 80. I can't see here the. I hope you can see the figures.
87.
Yeah, 87. The first figure is 87.
Yeah.
And here you see, with increasing age at the time of surgery, these figures get worse. The best voiding situation have, as expected, the young ones, and this get worse as they get older. Here we see those 13% who were unable to void, the use of condom urinal and indwelling catheter, condom urinal every night for undisturbed sleep, patient indication, he was continent during the day, condom urinal permanent, incontinent after stroke, he was previously continent, but a clear indication, indwelling catheters for nursing reasons, 92-year-old man, previously continent, and a patient with advanced GI cancer who was previously continent. The indications and history of the use of CIC is of interest. Of these 259 men, 3 had occasional mucus obstruction, all after many years later. All were PET-free, however. CIC residual urine, smaller than 200 cc, bedtime to reduce nocturia. Once again, that's a patient indication. If he doesn't want to get out of his bed during night, he makes a CIC before bedtime to reduce nocturia. All of these patients were continent and all were PET-free. Here, residual urine larger than 200 cc after spontaneous voiding. These patients had 2 to 4 times per day CIC. 5 of patients, 1 patient was PET-free, 1 patient had 1 PET per night, 3 patients were PET for safety. And the group of concern, hypercontinence, not so many. 8 of the 259 patients were hypercontinent. Without, we were able to find a reason for that. No obstruction, no scars, no strictures, nothing. They were, without an obvious reason, hypercontinent. That's the classical definition of hypercontinence. 4 times CIC per day, all were PET-free and were continent. Next, day and nighttime urinary continence. Our continence definition was less than 1 PET per day, and I give you percents of patient, daytime and nighttime. Again, patient age at the time of surgery. Again, patient age at the time of questionnaire. Here you can see overall 90% of our patients using this definition, less than 1 PET per day. The continent, nighttime continence is given here. And again, those operated at young age had 100% continence, and those operated at older age had worse figures. 194 overall, 90 overall, and from here to here with increasing age. Now in absolute figures, that's what I just showed you on the last slide. Overall daytime, nighttime continence, the definition less than 1 PET per day, 90% continent, 82% nocturnal continence. Now, PET-free rate in absolute figures during the day, daytime PET-free rate, 185 of the 259 patients were PET-free. Daytime PET for safety, 47 patients were a PET for safety. This leaves 25 patients who needed more than 2 PETs per day and using our definition were incontinent. That's clear, that's a 10% incontinence rate, almost 10%. It's high, but I think it's acceptable and we have to face it, and it's a matter of fact. Nighttime, PET-free, 1 nighttime voiding, half of the patients. Nighttime PET for safety, 92 patients. As we all know, nighttime incontinence is much higher than daytime incontinence and is shared by all types of orthotopic reconstruction. Now we come to the complications. Now listen carefully. This is the complication rate of the 1,000 neobladders, not of those we are going to talk about in a minute. That's the entire series. In all of our 1,000 neobladders operated till 2009. Meanwhile, we are at almost 2,000, but they are not worked up so well. The mortality, 90-day mortality, was 2.3%. Clavien grade 1 to 2 complications, 36%, and Clavien grade 3 to 5, 22%. So taken together, 50, 58, 60% of our patients had some form of complications. 2.3% died. That's perioperative. Now, long-term, ileal neobladder related tests, 3 of the 923 patients passed later on, all of them because of sepsis. The total complication rates, long-term Kaplan-Meier method, 40.8%, and the requirement for a second diversion needs to take down the neobladder and to put in either a second neobladder or a conduit or whatsoever, 3.2%. Again, that's the complete series here, not the series we are going to talk about right now. That's now the 259 patients with the ultra-long-term follow-up. Again, Kaplan-Meier graph. You just saw we had in the long-term 40.80%. Now Kaplan-Meier, the ultra-long follow-up, 27% of these complications because the tumor complications have been excluded. That's clearly understandable. But that's why we insisted in this, because of the long-term follow-up. Now, these are all the patients with surgical complications, Clavian 3 and 4 of the neobladder from the time of surgery till the time of survey of the 259 patients. Interesting group. No cancer complication, once again by definition. Kidney complications, 7. These are the kidney complications, and each spike stands for one complication, and the complication type is listed down here. One patient, renal artery stenosis with end-stage renal failure and dialysis, the only patient on dialysis. 5 patients, unilateral nephrectomy for non-functioning hydronephrosis. All of these patients come from the early phase where we used the Leduc type of anastomosis, which is, as we all know, prone to obstruction. Later on, interesting to see, very few obstructions. Ileoureterostomy, here in blue, 20. No, der geht aber nicht hier. That's the line for the ileoureterostomy. 12 underwent open reimplantation, 8 endourological treatment. Once again, the main cause for obstruction was a Leduc anastomosis. Here, neobladder complications of the 259 patients. 5 had neobladder complication, 1 had pouchitis, 1 traumatic rupture after a car accident, 1 had a CIC perforation, and 2 had stones. Stones have been a very uncommon problem in our series. Now, ileoureterostomy. 11 patients, no malignant obstruction by definition, all were excluded, all were treated endourologically, and finally, in blue, urethral complications, non-malignant strictures, all treated endourologically. These were the Clavian, once again, 3 and 4 complications. That's the kidney function. Serum creatinine preoperatively and 5 to 20 years postoperatively in these 259 main patients, including 7 patients with major renal function deterioration. We go one slide back, that's exactly these 7 complications. Top, the blue curve in the top here, these are the 7 patients that are included with major renal function deterioration. And what you can see, there is a 0.1 to 0.2 milligram per deciliter increase for every 5-year period. That's the age-related decline of renal function over this 20 years period. Febrile urinary tract infection. As you can see, a total of 17%, 20, 19, 16, 17%, that's the average rate, and that's during the last year before surgery. This is a common problem. 17% in 1 year, that's not nothing. That's bicarbonate therapy, just this line applies here. 40%, 28%, 25%, 18%, decreasing over time. 5 to 10 years follow-up, 10 to 14 years follow-up, 15 to 20 years follow-up, and greater 20, 18%. Again, this is the daily bicarbonate substitution. In yellow, that's giving nothing, no bicarbonate. As you can see, giving nothing, increases over time, and a large bicarbonate load, 2 to 3 grams, is decreasing, and finally there was no major substitution, but nevertheless a few patients still required bicarbonate. That's an overview of the patients. We discussed all of that: number of patients, mean age, residual urine, indwelling catheter, and what you see here, those that do best, not unexpected, are the young ones with the long, ultra long follow-up. They are still young at the end of this long follow-up here, younger than 70 years, no residual urine, no indwelling catheters, very few PETs during day, during night, no mucus problem, not much of a bicarbonate therapy, but a significant portion of infection. Now, association among patient age and clinical outcome. Clinical outcome means complication. That's what we knew beforehand, and all of you know age at the time of surgery is a significant risk factor. But for the age category younger 50 and younger 60 versus the older ones, and the risk for younger patients is significantly higher than for the older age group. That is contrary to the general expectation, but it's clearly the explanation for the ultra-long follow-up. These young patients had 30, 20 years, 25 years, 30 years to develop complications, and that's why the younger patients have a significant higher complication rate than the older patient. That's but not what is meant when we ask or explain to patients what they have to expect. Then we clearly must say, initially the young ones are the old ones are the bad ones. Increasing comorbidity was not independently associated with increased risk of complications. That was a big surprise for us. We did not expect that, but it was clearly statistically significant. Surgical complications and functional outcome. Clearly, we are able to demonstrate upper tract complications, significantly reduced urinary function. Also, what we did not expect, what has an upper tract complication to do with CIC or incontinence or infection or mucus tamponade, but it is significantly correlated. Upper tract complications, as soon as you have to operate or return to surgery, the urinary function is reduced. That's also true, not unexpected, for lower tract complications. They also show reduced urinary function, same problems. As soon as you return surgically and operate, the urinary function is decreased, and that's significant. And clearly combined upper and lower tract complications, highly significant rate of function impairment, mostly incomplete emptying of the neobladder, need for CIC, difficult to explain. Once again, I do not understand what the upper tract complication has to do with a reduced urinary function, but statistically significant, correlated. Now we come to my final slide. Here you see Albert Einstein. Why do I show him to you? It's not a surprise. You probably don't know it. He is the most prominent son of the city here in Ulm, where I practice. He is the hero of the city, and I like him in particular. He has said so many really prudent and intelligent sentences. In all of my talks, one or two of his sentences appear. And what I would like to close here with is, life is riding a bicycle. To keep your balance, you must keep moving. Standing still is no way to go. That's one of his famous sentences in a letter to his son. Thank you for your attention.
Thank you, Dr. Hartman.
I see you well. Do you see me? Yes.
Yes, we can see you, sir. We'll invite the question answer in the last, and then may I invite you for the next topic, orthotopic reconstruction, why it works or not. And then we'll have a question answer session after these two talks.
Okay, I agree.
Ja.
Jetzt kommt dann der zweite Vortrag gleich. That's my roadmap. Once again, I will start a short glimpse to the history because of the honesty of reporting. Very interesting point. Second point I would like to make, ileal neobladder is not always an ileal neobladder. Very interesting and important point. Worldwide declining use of orthotopic reconstruction. The relation between volume and function. Some thoughts on surgical technique. Shape matters. It's not irrelevant whether you make a U or a S or a N or a W or a Padua pouch or a Studa pouch or whatsoever. Now, first about the honesty. That's like a red thread running through these 100 years. For me, easy orthotopic reconstruction started in Germany. No, it's not correct. It started in Italy, but was published in Germany because at that time, 1888, the language of science was German. And the idea, the reconstruction of the urinary bladder, was brought up by pathologists in Bologna, in Italy. But what they did was not really honest. The mistakes they made, it was just one little dog. It was an healthy animal. What is fraud? It was not a cystectomy. I show you in a moment. It was a partial cystectomy. It was a high pressure reservoir and there was no follow-up. Dubious. The date of surgery was in June. The publication already came out in December. At a time without internet, fax, telephone, and so forth. Amazing. The authors were so hectic, they spelled their names even wrong. There was no follow-up publication, and this has been done by others 3 years later. Now, what was the fraud? 3 years later, a young doctor in Bologna did a post-mortem exam on the dog. And you can see here, this is the bladder, no cystectomy, no orthotopic reconstruction. That's what he did. He put in an augment and he opened up the bladder here. You can see the orifices here and here. And you can see the augmentation. So what he wanted to do was orthotopic reconstruction, but what he did was augmentation. And this goes on and on and on, and for every step in urinary diversion, I have a wonderful talk where you can demonstrate that nothing really went correctly. So the history of urinary diversion is overshadowed by enthusiastic reporting of preliminary results and withholding desolate long-term outcomes. The rule of publishing failures in the same journal as the initial results has been ignored frequently. So the mistakes have been repeated rather than being prevented. And another very interesting sentence on the diverting people. Ong was an excellent surgeon, what I learned in Hong Kong. But what he did, you can read here, following the example of Hunter, the experimentalist, who stated, don't think, try it. He performed this operation on 28 patients. That's far away from legality and ethics and so forth. These short thoughts to the history of urinary diversion. The modern times of urinary diversion include a detubularized reservoir with low end filling pressure and no formal anti-reflux mechanism. 1987 Gonheim, 1987 Hartmann, 1988 Studa. Almost within 12 months, these three published their ideas. The only changes, Ghanem kept his serous line tunnel. We are using a freely refluxive anastomosis since 96. And as you know from Urs Studer, he has his isoperistatic segment. Now, a important point. A neobladder is not always a neobladder. How can that be? This here, what I show you, is taken from Campbell's Urology in the year of 2007. And here you see there's only one ileal neobladder. This was born in Ulm in the year of 1986. Ghanem called his reservoir urethral cock pouch. Urs Studer, my friend and neighbor, Bern is very close by, till then, until nowadays, calls ileal bladder substitute and not neobladder, S-bladder, Kamei2, Vesica ilealia paduana. These have all been the names for these many reservoirs. That's the first publication, 1987, in German, Ilium neoblase. Neoblase is a hybrid word. Neo is Greek and means new, and bladder, blase, is German. And in English, a year later, the same. Neo, Greek, and bladder, blase. That's how it came about. So this is a scientific misnomer. In 2020 and many years before, orthotopic reconstruction and neobladder are synonyms. I don't mind, that's no problem. You just have to recognize, because the consequences are significant. There are major functional differences between different types of orthotopic reconstruction in regard to pressure, capacity, continence, compliance, complications, etc. And it's not sufficient to say, I did a neobladder. You must say exactly what you did. And saying, I did a neobladder, and to think it's a ileal neobladder, that's also not correct. So that's a matter of nomenclature or naming the right thing. Declining use of orthotopic reconstruction. Interesting phenomenon. It's not increasing orthotopic reconstruction, it's decreasing. And what I'm going to show you is based on 3 data sets. On our national hospital filling data set in Germany, 53,000 patients operated between 2006 and 13, published. And United States, 76,000 orthotopic reconstructions operated between 2001 and 2012. What you can see here is, in blue, orthotopic reconstruction remained low and decreased. And all the others, robotic surgery, conduit, increased. That's United States. The highest rate of orthotopic reconstruction was in 2008. But as you can see here, it was 11%, not very much. 11% of diversions in the United States in 2008 were orthotopic reconstruction, continent diversion. And since then, as you can see here, year for year, orthotopic reconstruction decreased, and it's below 8 nowadays. These are the German figures, 53,000 patients. You can see 2006, 2008, and 2013. Blue is the conduit. And in red, we have orthotopic reconstruction. Different from the United States. They had only 12%, at least in Germany. We had 37% in 2007. And it decreased to nowadays below 30, but steadily and every year. And again, these are nationwide figures. A light on the German situation. In German, that's the most favorable situation you can have. The annual number of muscle-invasive bladder cancer in Germany is 8,000. Our number of radical cystectomies per year in Germany is 6,500. Tremendous high rate. In the United States, less than 50%. Our number of urologists is now 5,000. Not operating, not hospital-based, 3,500. This leaves the rest for hospital-based urologists. And that's why the mean number of radical cystectomy per year and per department is 27. And 50% of the departments in Germany do more than 50 radical cystectomies per year. So Germany, as you can see, is in a so-called high volume situation. The majority of cystectomies in Germany is done at a high volume institution. Now we have to analyze, why is that? Wait a minute. This was a commentary from me in the Journal of Urology, and I clearly defined 3 points why it is decreasing. Now, point number one, 50% of all radical cystectomies are done by low volume surgeons. That's a major criticism. If a low volume surgeon who is not able or is not in command of any type of diversion, he always will do the simplest thing. Imperfect surgical technique leads to imperfect functional results. I will give you some examples in a minute. And no doubt, the robotic surgeon adopted a stepwise approach to a radical cystectomy and orthotopic reconstruction, and achieving oncologic efficacy was their main goal, and the diversion was of second priority, and that's why they even nowadays have an unusually low orthotopic reconstruction rate intracorporeally. Volume and function. I think you all and me, we are in one line. If a continent diversion ends up in incontinence, the operation must be classified as a failure. And there are no ways to argue and to discuss about it. Then it is a failure, a simple failure, and nothing else. And I have to remind you once again, daytime continence is determined only by the condition of the external sphincter. There is also no doubt. And nighttime continence is at the mercy of the functional characteristics of the reservoir. There's also no doubt. And here you see the absolute values. The maximum urethral closing pressure is given here during the day. And the pressure in the reservoir at no time is allowed to be higher than that. Then the patient is incontinent. And the same we know during nighttime, albeit at a lower rate. And these are wonderful studies done by Query team and published in the Journal of Urology. Now, what have been the crucial improvements and why should we do better? Detubularization, cross-folding, spherical shape, larger radius, greater volume, lower pressure. These are the key issues. And now a very interesting observation. I compare here orthotopic reconstruction during the day and during the night at pioneering institutions versus non-pioneering institutions. But the non-pioneering institutions are using exactly the same technique. The pioneering institutions I have chosen is Ulm and Bern, Studer. That's the daytime continence, and that's the nighttime continence. Now, when you look at the non-pioneering institutions, Munich, our neighbor, one hour by car to the east, they learned it here, they do exactly what I do, but they are only half as good in terms of success here. During the day, instead of 96, 54, during night, 66, 36. And the same is true for the ileal bladder substitute with Studer again. That's the Swedish figures. And this is University of Southern California, Indy Gill's figures. And when you look at them, they are not 92 as with Studer. They are half of that, 54, 53, during nighttime, 28, 32, 36, and not 70. Now we are left with a problem. What is that? The first explanation is the wrong shape of the reservoir. As soon as you leave the principle, detubularization, cross-folding, then U-shaped is not cross-folded. U-shaped is U-shaped and is folded only once. And when you look at the figures during the day, no wonder, not so much difference. As we said, daytime continence is guaranteed by the external sphincter, irrespective of the type of reservoir. That looks reasonably good. But when you look at nighttime, then the continence is no longer 50 or 60, it's just half of that. And the incontinence rate, 53%. So the first point, technically, that must be considered is the reservoir. And now we are going to spend some thoughts about the reservoir. Reservoir principles, ileal length for body of reservoir, forces 40 versus 60 centimeter, volume 400 versus 600, gut segment used, ileum versus colon versus stomach. We don't go through that, that's clear to all of you, I guess. Now everybody says, oh yes, I know the law of Laplace and I respect it exactly, radius, pressure, wall tension, that's correct. But when you look at the physical laws that apply, the law of Laplace is just one here, and all these others, Poiseuille's law, all of this must be considered, Bernoulli equation, capillary action, that all of this must be considered, and nobody does that. I read it with interest, but I don't understand it. Now, what does the law of Laplace? Describes behavior of thin-walled elastic containers. Ideally, the law of Laplace is for a soap bubble, not for a neobladder. And the problem when urologists look at the law of Laplace, the validity is limited to situations in which the wall thickness cavity diameter ratio is smaller than 0.1. That's the so-called thin wall restriction. I have heard or seen no urologist who considers the thin wall restriction a critically important point of the law of Laplace. That's here, that's the law of Laplace as we know it. Pressure, radius, tension, but then the wall thickness comes into play and it is done in millimeters. Means a factor of 1,000 times 2. Now, I don't want to bother you with a exhaustive discussion of Laplace's law, but I want to mention what it means and what it does not mean. It is not applicable to early stages of filling, when the neobladder is unfolding from a collapsed state. In later stages, when the neobladder is distended, then elastic effects are important. And we have to consider a bladder has viscoelastic properties, smooth muscle contraction, pressure waves, and there is a neurological response. So this law is esoteric, is an approximation. It can serve as a model. What actually happens is much more complex. Now, surgical technique. I said the critical point is you must have an adequate reservoir. Here is a standard ileal neobladder, and here is a U-shaped bladder. That's what most robotic surgeons use because it's faster to build, easier to sew together, and has side effects. As you can see, the volume difference is huge, 4 times the volume. The pressure twice as high in a U-shaped reservoir than in a correct neobladder. These are the robotic reservoirs. All of them, as you can see, U-shaped, 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 and all high pressure. Once again, an Einstein sentence: make things as simple as possible, but not simpler than that. I like this sentence very much. And what robotic surgeons do, they simply make it simpler than that. Now I come to a delicate point. As I told you, Urs Studer is a friend. Why are the others that are using his reservoir not achieving as good results as he does? Here, to be beyond any doubt, I took graphs from his original work in the Journal of Urology. And all of a sudden, his neobladder patients have prostate cancer. Or when we move on, they have recurrent prostatic adenoma. What is that? Urs does, because he has a smaller reservoir, he uses an increased outlet obstruction. When you operate with him, what I did many times, he leaves a piece of apex behind that clearly improves continence. That's good for his nerve sparing, that's good for an outlet resistance, and the consequence is, as I said, adenoma, anastomotic strictures, adenoma, I go on the bend back, carcinoma, and as he calls it, his unblocking rate, redo resection of the outlet, is 22%. But this is the key to his excellent continence data. As long as you tell the patient everything is fine, I have nothing against that. You can do that. It's no discussion, but you must know it. And the privilege of the ileal neobladder is it has a lower bladder, a larger capacity, and does not need maintenance of the apex, and nevertheless provides and produces the same results. Another point of importance, we all hear over and over, as long as it is global, it is okay. That's not true. And I'm going to show you why. That's a very interesting study. It's intracorporeal neobladder construction, and it's pressure flow urodynamic in cadaveric human orthotopic neobladders. Very, very unusual. Cadaveric ileum, intracorporeal robotic reconstruction, and pressure flow urodynamic studies. Very interesting. That's urodynamic of the neobladder without neurology, without motoric action. That's a very good idea, was a very good trick. And what these authors compared, Studer, circle pouch, U pouch, and W pouch. And here you see, again, original, no debate about the outcome. These are the original data. Even when they are all from the same length of gut, the W pouch has the highest capacity, the volume at first change, the highest volume at first change on a very good compliance. And the conclusion of this study was, as a result, we recommend in vivo application of a double pouch reservoir to undergo further testing and so forth. So they are not the same. That's why I'm saying an ileal neobladder is not an ileal neobladder. And as a consequence, Hussein in Buffalo He does meanwhile a robotic classical W ileal neobladder and has published it in the journal, British Journal of Urology. And he can compare what he did before that and now. And he says that's a world of difference. Now I'm close to my end. Conclusions. As we all know, but it must be said over and over again, the ultimate degree of success of a neobladder is translated into the continence status. Daytime is the external sphincter, irrespective of type of reservoir and whether detubularized or not. Nocturnal incontinence is more common and lasts longer than daytime incontinence and is shared by all forms of neobladder. Some degree of nocturnal leakage is a consistent finding, but the W configuration and the 60 centimeter reservoir offers at least continence sooner, particularly at night, and when you ask me, even better. So that's my last slide. Again, as you would now expect from Einstein, the purest form of insanity is to leave everything the same and simultaneously hope that things will change. We have to move forward. We have to discuss. That's what we are doing. And I thank you for your attention.
Thank you, Professor Hartman. Really very nice lecture. Before I hand over mic to Professor Gillen and Professor Raghavan, I have just one comment. In first 20 years, I was using your classical 70 centimeter of intestine to make the neobladder in shape of W or M. Yeah. In a long-term follow-up, many patients had a very huge bladder in long-term follow-up and they required CIC. So now I have reduced to 45 to 50 centimeter with 3 limbs. So what is your comment? They are doing well.
So your question is, initially you did a 60 centimeter reservoir?
70, your classical 70 centimeters.
70, and now you reduced it to 45.
45 to 50, yeah.
Yeah, and you get the same results, you say?
Because to avoid the over-distension of bladder in long-term follow-up, 10 years follow-up.
Okay. I have no arguments against that. That's your data. And if you like it and if you trust your data and you have a follow-up, a careful follow-up of your patient, but it's not my experience.
Oh. Thank you, sir. Now I hand over mic to Gillen, Professor Gillen and Professor Raghavan.
Dr. Jagdish Kulkarni want to ask a question.
Yeah,
Dr. Jagdish Kulkarni want to ask.
Yes. Professor, back in 2003 in BJUI, I reported the urodynamic results of Studer bladder, ileocolonic bladder, and sigmoid bladder.
I know your work.
And then I found that small intestine is much better in terms of both continence and what shall I say, in between loss of urine in between because of the contraction. That was really well. And this was there when Hohenfellner had suggested. One thing which I found was our problems of the left upper tracts were high because of the uretero-elastomotic stricture. Number one. Number two, being a lot of amoebiasis in our country, we found that whenever the patient had a diarrhea because of the things, the neobladder also started, becoming incontinent because of the same. And Hohenfellner told me that this is because the bowel remembers the same thing. Although you've taken it out of gastrointestinal circulation, and given them a new job, it still remembers that thing. So any of his segment gets into the higher, loss of feces, it happens there also. I don't know what your comments are.
Yeah, I would like to make a comment once again about the length used. There's one point that cannot be discussed. The larger the reservoir, the sooner the patient will be continent. And there is no question, because when a reservoir fills, the reservoir unfolds, and there's a major difference whether you unfold 500 cc or 250 cc. So these patients with a larger reservoir are almost immediately dry. And my experience, I'm just talking about my German experience, those with a smaller reservoir which see me and ask, why are your patients continent and not me? And then I tell them, yes, First, you have to wait. And second, it's more difficult for you to develop continence. Because this point that continence returns immediately as soon the reservoir pressure is zero. And the reservoir pressure is zero as long the reservoir unfolds. And when you have 150 cc in the bladder and it's still a zero pressure, that's an ideal situation. And this will never be achieved when you make your reservoir from a smaller volume. That's my first argument against smaller volume. My second argument is why you don't need the ileum, why you make it small. Now I don't hear you. Can you hear me?
Yes.
Okay, good.
Thank you.
Yeah, but you had another question.
Yes.
On stenosis of the left side, or what was it?
No, it was left hydronephrosis occurring more on the left side rather than right.
Yeah, when you do a classical ileal neobladder, the W with the little chimneys on each side, we published this last year, you get exactly the same figure. The stenosis or the obstruction of the upper tract comes when you bring the ureter from one side to the other. Yeah. This crossing denudes the ureter, ruins the little arteries and veins, and this makes a scary ureter, and that's the cause for a scarred ureter. And to avoid that, I have the little chimney on each side, which is above the common iliac vessels. And there it's very easy to make a tensionless and healthy anastomosis.
Dr. Ganesh has got a question.
Renal, the Q&A box you are looking after?
Dr. Ganesh want to ask a question. After that, we will open the question box.
Okay. There are 3 or 4 questions there.
Yeah. The question that I want to ask Dr. Hartman is, how do you measure the bicarbonate? Is it arterial blood gases or venous sample?
It's arterial.
So every patient has an arterial blood gas and you decide on the basis of the pH to put them on bicarbonate.
You're right. When it's done by the home physician, I cannot be sure. But as long as he's in the hospital, it's arterial.
Thank you.
And in our system, as you know, we keep, at least till recently, we kept the patients for almost 4 weeks in the hospital.
Dr. Hartman, it is a great opportunity to have you with us because everybody respects you a lot in this country. We have got a few questions for you from the delegates. One of the question is from Sanjay Sureka from Lucknow. He's asking what is the impact of neoadjuvant chemotherapy on neobladder regarding the functionality and the complications.
Yeah, okay. I have to be honest. When you read in the Journal of Urology my paper on the 2,500 cystectomies, it is a surgery-only series because I do not trust, and even nowadays, on neoadjuvant chemo. So I have a lot of experience with neoadjuvant chemo from patients that are referred to me, and I must admit I can say nothing negative about chemo. Not more complications, not more difficult. That's what I clearly must admit. I do not see problems when the patients had, even nowadays when they had immunotherapy, I see nothing, but also with neoadjuvant chemo, there was no negative impact. I must commit that, and I'm not alone. There are many Memorial Sloan Kettering, other institutions that clearly show neoadjuvant chemo does not have any negative impact on the surgery. Is your experience?
Dr. Sudhir Raval, you were also discussing the same thing in the last meeting. So do you do any precautions if you are going for a neoadjuvant chemo or adjuvant chemo? More than that, adjuvant chemo, like catheterization or anything in the post-operative? In the adjuvant chemo, will you take any precautions before chemo? Will you put a catheter in the neobladder or just have the chemotherapy after?
Then I do adjuvant chemo.
Yeah, adjuvant chemo.
Yeah, look here.
If there is, yeah.
A catheter in the bladder is crucial. That's absolute precondition, no question. You must do that. You must irrigate your patient. He must have a catheter in the neobladder.
And regarding a lot of surgeons give only 5 years of bicarbonate.
Yeah.
Do you think that is it enough, or gradually will the neobladder get accustomed to the changes, or body get accustomed to the changes in the pH?
This can be done. I agree. After 5 years, not much happens, and even when you follow up the patient up very closely, you miss it because it comes. You check him this week, and 6 weeks later he has a problem. But I agree. That's a very philosophical decision. Stop it after 5 years. Okay, I agree.
Raghavan, do you have one more question? Is there in the? Can you just share the question, Raghavan?
Say it again. I didn't hear you. Say it again.
Asking my colleague. Raghavan. Do you avoid neobladder in any stage like T3 or in advanced stage? Do you avoid neobladder, or you proceed with neobladder rather than conduit?
As you saw, our 1,600 patients and 990 got a neobladder. Whenever it is possible, we do a neobladder. We do it even with positive lymph nodes, not N3. When it's a bulk, we don't do it. But if 1 or 2 nodes are positive, we do it. And we also do it if the tumor is outside the bladder. T3, I also remember cases T4 where we did a neobladder. Our indication is very liberal. And we discuss it with the patients, and we ask him before surgery, how much pressure do you exert on getting a neobladder? And some patients say, no way, if I wake up with a neobladder, I shoot myself. I remember such patients.
Okay. Sir, in diabetes or old age, do you like to avoid neobladder? Because that is the way in which a lot of surgeons does here. So do you think that in diabetes and old age, you have to go for conduit rather than neobladder? What is your opinion about that?
As I said, whenever possible, we do a neobladder. Whenever possible. And your soundtrack is occasionally interrupted. Say it again.
Sir, in diabetes and old age, is it okay with neobladder? Should we avoid neobladder?
Diabetes and old patients.
He's asking in the patient who. Yes.
Diabetic and old patients.
Do you avoid bladder in patients who are?
I can't hear you, not at all. I assume
exactly.
About old patients.
Yes.
We have no chronological age limit. The oldest patient who received a neobladder, it was his will, was 92 years of age. He was chairman at the Karolinska in Stockholm, and he insisted. He spoke to me like to a young boy. He told me what I have to do. And I told him, you are 92 years, you are too old. And all the stories says that no way you put in a neobladder. And I did, and it worked well. He was highly motivated, of course.
One question from the audience. What if we are increasing the length of neobladder beyond 60? Will it be useful? Or is there any optimal volume you prefer to have for neobladder? What is the optimal volume for a neobladder in long term?
The optimal what? Optimal
volume, size.
Volume. Yeah. Okay. Yeah. We ask the patients not to exceed 500, 550, maximum 600. I remember a shepherd, a stupid patient, he was proud to accommodate 2 liters in his neobladder. That's a stupid idea. 500 is the limit, 550 maximum, but not more.
Any other question, Dr. Raval, Dr. Raghavan?
I don't have any more. Raval sir?
No, I think he has covered. I wanted to know what age he has, at what maximum age he has done the neobladder. He has told that. So that's great to hear. It was a great talk. Now, yes, sir. Dr. Kulkarni.
Can I say one thing?
Yes, sir.
I just want to know what is the rate of undiversion in your series. I saw about 2% of something. Is that the one? And was it conversion into ileal conduit or a re-neobladder?
Both, majority conduit, but also I remember we published it in the Journal of Urology last year. 1/3 neobladder and 2/3 conduit.
Okay.
But it's very demanding surgery. I would like to say words of caution. When you do that, you must be a really experienced surgeon. Redo operations following neobladder with a new diversion, that's among the difficult things that can expect you.
Why would a neobladder be converted to another neobladder, sir?
That's what he said. He did the review.
One question from audience. After neobladder, is it possible to give radiotherapy? A question from audience. Can we give radiotherapy after neobladder?
Yes. He's muted. He's muted. He's muted.
No, it's okay.
It's okay again?
It's okay.
Can you hear me again? We try to avoid radiation following orthotopic reconstruction whenever possible. And that's the philosophy of our radiologists. Whenever possible, we don't do it. No further
One more
questions.
question from the audience. Is it mandatory to have CIC in all patients after neobladder? Can you hear, sir? Is CIC mandatory as a protocol in all neobladders in the initial few days?
Say it again, please.
Is clean intermittent catheterization, should we do it in all patients of neobladders, or should we do it like a protocol?
We don't do it routinely. We discuss it and show the patients. Many of them had a TUR and know what a catheter is, and we tell them, look, that's a catheter, maybe that you must learn it, but we do not a training session on it.
One more question that has come. If a patient develops renal failure later, should we convert neobladder into conduit? One question from the audience.
We did not have, we had one patient who was on dialysis, as I showed you. And from the other 15 or 2,000, it's 17 meanwhile. But we never did an undiversion. We put in a catheter, for instance. We did simple things, but we did not undivert the patients to a conduit. We didn't do that. We believe that this gives more the anesthesia and the operation. After every operation, creatinine gets worse. That's what we all know. So this would be another step in the wrong direction.
between Studer, serous line pouch, and Hartman, what is the essential difference in the long term between Studer's pouch, Hartman pouch, and serous line, Mansoura pouch? These are the three neobladders we usually do.
Yeah.
What is the most important difference?
Yeah, when I can give you 10 points why I would not do a Studer. If you want to hear them, I can quickly go through them.
Sure, sir.
Number one is the reservoir is too small. The body of the reservoir is from 40 centimeters. That's point number one. Point number two is I do not understand why I use a 20 centimeter chimney for the urethral implantation. Number three, I do not want to have the crossing of the left ureter to the right side, which is required, and it is in a very dangerous location. It's right high up in front of the aorta. When you remember the Studer technique, the left ureter crosses way up, almost below the kidneys, comes from the right side to the left. That's what I don't want to see and I don't want to have. I do not like the folding and the rotating. Why to make it so complicated? A W, you arrange your ilium in a W and there it is. And then if you do a Studer pouch, you have to fold and to fold and to rotate, and finally you do not even know where you are. Makes me crazy, rotating and folding. Yeah, these are high anastomosis, high up, chimney not necessary. Why not include the 20 meters of the chimney into the reservoir? Then you have the 60 centimeters. Why rotate and cross-fold simultaneously? One is enough. These are surgical technical considerations. Functionally, it's okay what he does. I have many of his patients. They are fully okay. No question. That's not the problem.
And Mansoura?
Yeah, Mansoura, the main criticism is I'm totally against reflux protection. You do not need a reflux protection. And there is a prospective randomized trial coming out of Los Angeles where they compared the Mansoura technique with a refluxing technique, and the clear result was statistically highly significant advantage goes to the refluxing neo-implantation. And that's why do a complicated neo-implantation again, which creates complications, you know. If it would create no complications, okay.
Sir, in your neobladder, if there is a recurrence or if you want to undivert, there is no ileal stem. So again, we have to refashion a small intestine. So is it easy, other techniques for reversion, like later conduit creation? So if we want to have a undiversion,
yeah,
in Hartman pouch, there is no stem. In Studer, there is a stem. So it is very easy to just undivert. So is it an important point?
Okay, that you mean when I make the chimney of Studer to a conduit?
Yeah.
Okay, but you can make out of the neobladder 2 conduits. If you want.
Agree, sir.
Thank you. Thank you. Very well.
Thank you, sir. Any other questions, Raghavan?
One more thing. Thank you.
I think it is 8 o'clock. Close the shop.
Yeah, we'll one case discussion is there isn't Dr. Rawal?
I think there's a lot of connectivity problems, Ginil. So
Yeah.
there is.
Yeah.
I
He
discussed,
wants to call it off. I think just check.
I discussed with Dr. Sudhir Rawal, sir. He said probably we can stop because
Yes.
it was planned from 6:30 to 8. It is sharp 8.
Can I make a final comments?
Yes, sir.
Yeah,
Please.
of course.
We are all waiting for you, sir.
Okay, Professor Hartman, it has been a great pleasure to have you. And there are many takeaways from your talk today. But the major things are, first is honesty, what you have displayed. That exactly what, it's a lesson for not only for us, but also for youngsters, that you have to produce the data honestly and listen to it. You also showed us that about the long-term follow-ups of these patients, 40% complication, which is very high. You also told us that the number of neobladders are coming down across the world. You also said that it is the shape of the bladder which is more important rather than the folding and unfolding and thing. Also, you made a point that the left side need not cross across the mesentery, which will reduce our upper tract damage, which we had because we used to use Studer and crossing, as you very rightly said. The one problem in Indian scenario is a mucus production, which has been our bugbear. Although I guess you don't have that much of problem. Mucus-related stone diseases, which are seen in us, that's the problem. Overall, you have said that initially this is a very select group, and you've been very honest to that, and we appreciate that. And you also said that, well, it's whenever possible, be it octogenarian or nonagerian, perhaps neobladder is possible in all cases. Well, with this, I thank you very much for giving us this new input at the end of 3.5 decades, which is a great thing for us. We did have the dream, as Dr. Rawal said, that to have, and as Dr. P.B. Singh said, to be chairing your session is a great honor for me. Thank you very much. This is a SOGO 6 meeting, and for all the SOGO members, I want to tell you that, well, Dr. Rawal has already said that we are registered now, and we will start getting the further activities in a short while. With this, thank you very much, and good night, and have a very safe.
Thanks, sir. Good night.
Thank you, sir. Thank you very much, Dr. Sudhir. Thank you.
Thank you.
Yes, sir.
Thank you, sir.
Thank you.
Thank you. Good night. It was a pleasure.
Thank you, sir. Thank you.